Well, thank you. I'm delighted to be here with you today. I had a great time with the patient meeting last year in Toronto. I've been looking forward to this one. I know that there are some people in the audience who have really spent a lot of time learning about their Alpha1 and are going to pose some tough questions. That's why we've invited Darcy along. And there are some folks who are just getting up to scratch and need the basics. So there's lots and lots of stuff in my talk and about 3 hours worth, so bear with me, we're going to rocket through it. Before I start all of that nonsense, I just want to, in case I don't get to the podium again, in case I'm locked out later on for some of the things I say, many thanks to Angela for arranging all of this. She has been a wonderful, wonderful director, executive director of Alpha1 Canada, and she's been doing some incredible work behind the scenes. So if you folks get an opportunity, you should be nominating her for the Order of Canada or something along those lines. Let's hear it for Angela. All right, as you've heard, we docs who do research have conflicts. I have worked with a number of really dodgy companies, so be careful about what I say. I want to cover a lot of territory as well. So what I do want to talk a little bit about is COPD, and forgive me, it's a scary word, and there are graphs and everything, epidemiology. It's perhaps important for you to understand the larger context of where your disease fits right now. I want to talk a bit about Alpha1, of course, and Alpha1 antitrypsin deficiency in Canada, some of the latest research. I want to talk about how that research might influence your care. I want to talk about Alpha1 research in general. How do you find studies? Is it important to participate in studies? How do you evaluate a study you might be about to participate in? I do want to say a few things about general COPD, and I'm going to take a very top-line view of COPD and suggest where some of the trends are now, and perhaps suggest you reevaluate your own therapy in light of where COPD treatment is going. And we will finally, I think, get to a summary, and if there's time, certainly take some questions. Some caveats, some warnings. I'm going to be talking about the intravenous treatment. So I know for some people the term augmentation therapy is new. We mean the intravenous treatment, Prolastin if you want to use brand names. That, of course, is talking about lung disease, and I'm a lung doctor. It has nothing to do with liver disease, but I will mention a little bit about liver disease as we go along. There is one augmentation therapy product available in Canada at the moment. There are several that are available around the world, different brand names, different purification processes, but we think, given that it's purifying one of the body's natural proteins or glycoproteins, that these things are all pretty much the same. We want to talk about some of the treatments that are available to people with COPD and Alpha1, but remember, not everybody is the same. So I'll offer some general guidelines. You have to go back to your doctor and talk about what is right for you, and you may be one of the exceptions. You'll see what I mean. Now, I warned you, epidemiology. Speakers often have their favorite slides, and I think this slide I will never, ever retire. It talks about American data, forgive me. Next slide, I'll show you some Canadian data. And it talks about American data from 1965 to 1998, just before the turn of the millennium. And that was a very important time because something very important happened. You see, the title is about tobacco consumption. Now, there's some people in the room who have less gray hair than I do, which means I may have to explain the significance of the 1 year before this graph starts, 1964. That's when the US Surgeon General said to the public at large, tobacco smoking causes lung cancer and lots of other really bad stuff. So again, for the people in the room who have much less gray hair than I do, picture an episode of Mad Men. We're talking about people smoking everywhere. They're smoking in offices, in doctors' offices. They're smoking on elevators, in cars, in restaurants, everywhere. Half of the North American population smoked. But by now, Darcy said millions, he's correct, the number is down to about 20% of the North American population. So, what should happen to deaths from diseases that are caused by tobacco smoking? Well, you would expect them to, and you'd be right. The first bar, that's coronary artery disease, heart attacks. Death rate drops 60%. Next bar, strokes, down by about the same. Other, we call them cerebrovascular diseases, stroke-like things, down by about a third. I'll hold back on COPD for a dramatic effect. We'll go to the last one. All-cause mortality is kind of level or down a little bit. COPD, tobacco-related. Tobacco consumption is on the decline very dramatically, so of course COPD deaths are up 163%. Most docs are amazed at that, let alone the lay public. Respiratory docs, people who are immersed in this field, know the explanation is very straightforward. By definition, if the tobacco damage to the lungs is what we call COPD, chronic obstructive pulmonary disease, the damage is relatively permanent. The rest of the story is one that you hear all the time: the population is aging. We are harvesting now the consequences of tobacco smoking that was done through the middle of the 20th century. This trend is inescapable. It's still going on. We expect COPD to be the third most common cause of death on the planet by the year 2020 or so. The Americans currently call it their third most common cause of death. In Canada, it may be still in position number 4, but it's inevitably going to creep up to position number 3. What that does mean, as you look at Canadian trends over several decades, rising death rates due to COPD, is that COPD has hit the front burner. There is a lot of attention being paid to it, and somewhere in there, as we talk about the right way to treat COPD, we should be talking about the very special form of COPD called Alpha1. But lots of things get ignored. For example, I astonish doctors when I point out that the demographics of COPD have changed. We have this picture of Marlborough country and this fellow on the back of a horse smoking his cigarettes. And that's not the picture anymore. This year in Canada, and for that matter last year and the year before and the year before and the year before, more Canadian women lost their lives to COPD than lost their lives to breast cancer. Not that you would necessarily know that by opening up the, say, Toronto Star or the Weekend newspaper and looking at their latest health story. Have a look at this. I copied it from my Twitter feed several years ago, and it just astonished me. On the left-hand side of that graph, the circles represent the amount of funding given to charities for various disease entities. On the right, death rates due to various disease entities. So the top, in pink appropriately, lots of money being raised for, look up at the legend, breast cancer, and no disputing the importance of breast cancer, devastating disease, but in terms of mortality, we've made a lot of progress. It's actually not the numerically most important disease around. COPD, your disease, if you will, if you've got a lung involvement from your Alpha-1, well, it's not raising a whole lot of money, it's way down there, but on this particular graph, it was listed as the number 2 cause of death and disability. So we've still got a lot of work to do. There's a lot of blame being thrown at patients with COPD. We don't seem to do that as much for cancers and heart attacks, but there's a lot of notion that somehow COPD patients did it to themselves. And I think certainly Alpha-1, being tightly tied to its genetics, has a way of turning that story around. So Alpha-1 antitrypsin deficiency in Canada, you've heard a bit of this, and Darcy gave us a great introduction. I'm going to take us back momentarily to some ancient laboratory stuff. Those two fellows, Laurel and Eriksson, in 1963 were working in Malmö, Sweden. They were analyzing blood samples that had been sent to them. And on the right-hand side of that slide, what you see are a bunch of blobs across, it's called a protein electrophoresis plate. And those blobs represent different components of circulating proteins in the bloodstream. The bottom sample is the normal one. The top sample might be a sample from someone in this room. It's missing a band. Second from the left, that narrow band, that appears on the bottom but not at the top is the alpha-1 band. And Laurel and Erickson figured out that this was a common pattern in Scandinavia. It was about 1 in 4,000. They recognized it was a 52 kilodalton protein. Try that one out in your friends. And it was associated, when they tracked it back, to people who had emphysema that tended to be at the bottom of the lungs and that tended to occur rather early and perhaps without as much tobacco smoking as was thought to be common in COPD. Now, I should point out, though I'm about to go on and on talking about lung disease, that there are two really important consequences of producing this abnormal protein. One is it doesn't fold up very neatly and make its way into the bloodstream. So in the left-hand photo, what you see are what the pathologists call inclusions, protein stuck in liver cells, where damage can occur in children and in adults, ultimately cirrhosis or even liver cancer. On the right, that's what I'm going to spend most of my time talking about, that very loose-looking, very non-dense, spongy stuff, that's lung, and it's a little moth-eaten because, as Darcy explained, white blood cell elastase, normally present to help us fight bacteria, has actually broken down some of the lung substance because alpha-1 wasn't there in adequate amounts to protect the lung. Here's a better comparison. Two lung pictures on the left, normal, dense, spongy lung substance, a good place to exchange oxygen, to expose oxygen to the bloodstream. But on the right, that loose, moth-eaten looking lung, that's emphysematous lung that's been digested by elastase. And we're trying to prevent that. And by the way, in research, we're trying to quantify that. Now, again, I keep talking about augmentation therapy. We'll spend a bit of time on it. Augmentation therapy is nothing new. It's been around for a quarter century, actually more than a quarter century. And one of the first really big studies was published in the New England Journal of Medicine by people working at the NIH, Mark Wiewers and colleagues. And what you're looking at is the sort of graph that a pharmacologist would look at. You're seeing several lines there. It represents half a dozen people with alpha-1. The y-axis is a measurement of alpha-1 levels in the bloodstream, and as Darcy explained, they're kind of low in alpha-1 antitrypsin deficiency. Usually not zero, but they're low. And what the investigators did was gave injections once per week at a dosage that may sound familiar, 60 milligrams per kilogram, to these half dozen or so folks, and you see the blood level rocketing up and then gradually going down again. And we're actually not too concerned about it going up. We're not concerned about the peak levels. What we're concerned about is keeping the levels always above that dashed horizontal line. That's called the protective threshold, and as you heard, about 10 or 11 micromoles. So they established that they could give purified alpha-1 to people who didn't have enough. They could keep the levels above a protective threshold by infusions once per week. And by the way, and I won't show you the information, but they could also wash out some of this infused alpha-1 from the lung so they knew it was getting to where it was supposed to. And so alpha-1 antitrypsin treatment, augmentation therapy, was made available, approved by the regulatory authorities in the United States, the FDA, in Canada, Health Canada, and in Germany. However, that was not the way the Canadian Thoracic Society viewed things. They said, wait a minute. This is all biochemistry. This is all pharmacologist stuff. We're lung doctors. We're kind of insulted here. We're in charge of emphysema, and the way we track emphysema is to get you to, and I heard people starting to exhale, blow, 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 blow out through a spirometer. They said, we don't care about the blood levels. We want to see that FEV1, that magical number, that it doesn't drop down as fast when people get this intravenous infusion. And so they said, further research is required. I will tell you that until 5 years ago, I was still getting referrals from respiratory specialists in this country to see if I had access to this research stuff, prolastin. Totally unaware that this has been a prescribable therapy in Canada for more than a quarter century. This was a devastating statement that produced profound ignorance in the Canadian respiratory community for a very long time. Now, the request was very simple. Spirometry. Everybody in this room, I think, has done it. And it's a pretty simple measurement, and it sounds like a pretty simple ask. You say, let's start with a group of people who have alpha-1. Some of them are going to get the intravenous treatment. Some of them are not going to get the intravenous treatment. We'll keep track of their FEV1. Nothing could be simpler. Why don't we do that study? But you have to plan the study and look at the numbers, and you discover, of course, that FEV1 is kind of a noisy signal, and it changes slowly, even in this disease. So when you calculate how you do the study, you discover that you'd need to study people for about 5 years. That's a pretty long study. You'd need to recruit people to get treatment, 500 of them or so, and another group, another 500 or so, not to get treatment for those 5 years. 1,000 alpha-1 patients. Ain't gonna happen. Hasn't happened, never gonna happen. I'll show you why. I'm gonna introduce you a little later to something called clinicaltrials.gov, which is where big important studies get posted so researchers can declare what they're working on so that later on they can't find something else in their data and pretend that that's what they were after all the time. So clinicaltrials.gov posted the RAPID trial, and I'll point out that the trial is now completed. I'll show you the results in a second. It got started and finished over a 7-year period. Not on this graph, but I will tell you that it took 24 international Alpha-1 centers working in collaboration for those 7 years to study for 5 years? No, 2 years, 180 patients. That was the biggest trial of its time. There's currently one underway that will be a little over 300 patients. But we're still talking in the low hundreds, not 1,000 patients. And again, the FEV1 trial is never going to happen. I mentioned the RAPID trial. It got published in 2015. You've heard of The Lancet. That's where it appeared. It said people who get the intravenous treatment have better preserved lung density. It was a 2-part study. I'll show you the 2 parts. What you're looking at on the y-axis of this graph is lung density. And of course, it's going down in everybody in this room, alpha-1 or not. We all lose a little bit of lung density over time. The idea was to track the lung density, the sponginess of the lung during a period of treatment. The first 2 years was what we call the double-blind period. Some people got intravenous treatment with active treatment. Some people got intravenous treatment with this just saline. Sorry, they didn't get anything. And these were the results we saw. And as you can see, people who got the active treatment, the augmentation therapy, had a slower loss of lung density, and there's a number there attached to it. Their lung density loss was 1.5 grams per liter per year. Now, in the second 2 years, everybody got treatment, thank goodness. And what we see after the better result in the intravenously treated patients during the double-blind portion is they continued to benefit from continued treatment. And the folks who got the delayed start treatment, well, their rate of lung density loss kind of leveled out, but they never did go back and recover the lung density that they've lost. So one of our messages from RAPID was the earlier you start, the better, because once you lose it, you don't get it back. Intravenous treatment is about slowing loss, not about building new lung tissue. There were a number of other results of RAPID, and I could go on for about another hour telling you about subsequent analyses. But I'll introduce this one because it's relevant to some research that's going on now. What you're looking at on the y-axis is the protection of lung density. The higher you are on that graph, the more protected your lung, the lower your loss of lung density per year. Across the x-axis is your blood level of alpha-1 antitrypsin. Now, in the RAPID trial, you either didn't get treatment or you did get treatment at a standard dosage, so you wouldn't think there'd be much chance to evaluate different dosages, but in a way we could. And it's a little complicated. I'll get Darcy to explain it if you want, but if people are different body shapes, heavy, thin, etc., and get the same standard 60 milligrams per kilogram per week, some people achieve higher blood levels than others. It's just something pharmacologists call volume of distribution. And so taking advantage of this, we discovered that if we put together all of our data from the RAPID trial, the higher we got the blood level, the better the protection, with no leveling out. Leveling out would mean we've hit the maximum effect, but we didn't see any leveling out. So we look at this and say, well, 60 milligrams per kilogram is good, but maybe 90 or 120 would be better. And that, in fact, is part of active research at the moment to test higher doses. So I have one very practical tip for everybody in the room. I hope nobody needs to take advantage of it, but just in case. Doctors who aren't familiar with Alpha-1 will write a prescription, if they dare, at 60 milligrams per kilogram per week. It seldom ends up being a round number. Every vial of alpha-1 antitrypsin protein that comes to your infusion site or to your home is 1,000 milligrams. If your dose happens to work out to 4,200 milligrams, and that's what your doctor's written down, the infusion nurse might, if you're not paying attention, take the other 800 milligrams and pour it down the sink. Please don't let that happen. So everybody's dosage needs to get rounded up to the nearest vial. And if that hasn't happened, please make it happen. Your doctor's going to have to write the prescription, but tell him he or she needs to do that, okay? By the way, the FEV1 stuff, I'll just point out, and it was buried in one of our publications, that there is a relationship between our lung density measured by X-rays and that old-fashioned 200-year-old measurement done with spirometry. And this funny-looking graph says, on the y-axis, the better your CT scan lung density protection, the better your FEV1 rate of decline protection. This was evident only after the 4 years of the RAPID trial, and it simply means that FEV1 catches up as a signal, but it's kind of slow, it's kind of noisy, and the CT scan information got there first. What do these differences in lung density mean? And we're going to talk about some scary stuff here, but if you lose enough lung density, if your emphysema gets to be bad enough, you may lose your life, or you may be lucky enough at that point to get a lung transplant. That happened to half a dozen people in the RAPID trial, and it turns out, and you can see there's a horizontal line on this graph, it happened when lung density got to as low as about 20 milligrams per liter. 20 grams per liter. And what we then did is modeled out what that meant to people who entered the RAPID trial. They're pretty average alpha patients, maybe like folks here in this room. This is where they started, and you can see that without treatment, how long it might take people to get down to that, if you will, terminal value, where they might die or need a lung transplant. Then, if we give intravenous augmentation therapy, the line flattens out. It takes a lot longer to reach that terminal point, and the difference is about 6 years. So we can now, courtesy of RAPID, start putting some meaning to those numbers and that slowed rate of lung density loss. What Alpha-1 research is underway now, you can certainly look around. Angela knows and keeps people posted, courtesy of Alpha-1 Canada. You might also, and I'm going to make a pitch for joining up the registry. If you've joined the registry and shared your information with us, and if not, I'd encourage you to do so. Sinead Callery is here from our registry just to tell you all about it and gather up that information. But we will keep track of people with Alpha-1 in this country, and amongst many other things that we do, looking at the data, we will certainly inform people about research that's underway. If you navigated to our website now, we had a couple of broken links to fix, but you would be able to get to a description of some of the clinical trials that are underway. This would include the SPARTA trial, and this is a look at people getting double the dose of Alpha-1 versus the usual dose of Alpha-1. It's a bit more complicated than that. It's described on the website. There is a placebo arm. So it's probably not for patients in BC where you have access to augmentation therapy, but it is an option for some of our patients in other parts of the country. This, by the way, is the website link in case you wanted to navigate there, but I do encourage you to speak to Sinead before the end of the day if you don't belong to the registry. registry, the Alpha1 registry, is different from Alpha1 Canada, and although we talk to one another, we can't share your confidential information, so if you haven't signed up specifically to the registry, we won't know about you for sure. What's next? There are lots of other things that are just on the horizon. So for example, we're looking at pills that might do the same thing as intravenous treatment. It's a dream that goes back a long way, but there is a tested anti-elastase pill called alvelestat. It was tried out in general COPD and put back on the shelf by the large company called AstraZeneca. A small biotech company based in the UK called Mereo Biopharmaceutics has pulled it back off the shelf and said, we need to test alphas. And so we're hopeful that patients taking this alvelestat will give us a signal that there's something important happening to protect the lungs in alpha. We have a 1-month trial coming up, and if that works out, there'll be some longer-term trials. Pills would be neat. Second one down, believe me, this had me running to the cosmetic shelf. I had no idea that hyaluronic acid was the fountain of youth. Apparently it is. You can smear it everywhere, and it does in the wrinkles and the aging skin. Hyaluronic acid actually stabilizes elastin. Who knew? And it can be inhaled quite safely. And there's a theory that it can stabilize elastin in the lung. So maybe not pills, but maybe inhaling something that's a simple chemical could do the job that the intravenous treatment does. So again, we have a short-term trial coming up. And if there's a signal, we'll be going on to a long-term trial. And then finally, we almost got started on a liver treatment, and we will be working with our colleague, Dr. David Wong at the Toronto General Hospital at future liver disease protocols. There is this wonderful way of inhibiting what's called mRNA. Everybody knows what DNA is. It's the overall blueprint of the body's substances. mRNA is the sort of intermediate that goes out there and produces proteins. And there's a clever new technology for stopping mRNA in its tracks, stopping the production of protein. The lung disease folks out there, you don't want to stop your alpha-1 production. Liver disease folks do want to stop their alpha-1 production. They want the liver to stop filling up with bad, misbehaving protein. And this would be a way to do it, and it's on the near horizon. The first mRNA inhibition therapy, by the way, has just been approved for a rare neurological condition where protein builds up and damages the peripheral nerves and the eyesight. So this is going to be a coming technology for what we might call rare genetic diseases that produce an abnormal protein. You can go out there and look for your own trials, by the way, and I mentioned before clinicaltrial.gov. You can navigate to that website. You might find it interesting. You might find it interesting if anybody ever approaches you about a trial or something research-related. You can go there and see if the trial's been listed. You can see that there's a spot where you can start typing in the name of your interest. Or if you start typing in alpha-1, there's a helpful drop-down list that said, oh, do you mean alpha-1 antitrypsin? And if that's the case, you can click on that. And when you press search, up will come 79 clinical trials listed. Now, you might look down on the lower left-hand side, and these are not all active trials. Some have been completed, some have been terminated early, some are actually recruiting. And it's also worth pointing out that being on this website doesn't mean they have some sort of government approval. Not at all. There's a standard warning that says, hey, we just took down the information. The trial, evaluating the trial, that's up to you. But I will point out that you can find things like this. So here's a look at the natural history of liver disease in alpha-1. You can get details about what's involved in the trial. That sort of information might be listed. This particular listing was quite comprehensive because if you clicked on the spot that said who's involved, up would come a list of names and even phone numbers and emails, so you could get directly in touch with the coordinators running those research programs. You can find a carbamazepine trial with liver disease. That's simply taking a pill that seems to encourage the liver to get rid of extraneous protein. Carbamazepine is an anti-seizure agent, widely used. We know what it does and doesn't do, and it looks as though it might have some side benefits for the liver, or at least that's the purpose of this study. You'll hear later from Sandy, and he's involved in an epigenetic study of alpha-1. trying to figure out what else goes on other than the basic genetic information, what turns on and turns off genes that also play a role. And again, there's a list. And when you find names like Robert Sandhouse, I don't actually know Robert Sandhouse, I know Sandy Sandhouse, or for that matter, Charlton Strange. I know a Charlie Strange, who's one of the world's experts in Alpha-1. You can be pretty reassured that this is a quality research trial, whether it's appropriate for your clinical situation or not. Finding these people, university-affiliated people, can be very, very useful. The reason I point all of this out is because there are also some other things you may come across as you wander through the World Wide Web. I get this question often, and if you cruise around, I will direct you to the COPD Foundation. They have a little statement about stem cell treatments. Bottom line, watch out for slick websites like this. Please don't go to Mexico for stem cell treatment. Sunshine, burritos, whatever, please don't go there for stem cell treatment. And one of the markers that this is really not on the up and up is the long list of diseases that this clinic offers to treat. Anything you could possibly, the photo is actually cut off. There's a list that goes down through the floor of diseases that are treated. COPD is apparently cured, whether you're 25 years old, as this fellow is, or 55 years old. The answer is these stem cells, which they will suck out of the fat in your abdomen and infuse back, presumably with those little chemical symbols in the background that makes it all really slick. And here's the guy in charge. He's not an MD, he's a PhD, but he runs a really great website. Stem cell treatment is really exciting. As you know, stem cells are pluripotential cells. That's doctor jargon. It means they can do anything, theoretically. And if you think of the first embryonic cell, it becomes all the cells in the body, muscle cells, bone cells, nerve cells, etc. And we can actually harvest some stem cells that aren't quite as open-ended, but we can harvest stem cells that can produce blood elements and connective tissue elements and other parts of the body. The trick is, how do you infuse them to do all of those things that they're supposed to settle in the places where they're supposed to? And the answer is, we're working on it. And there is no approved stem cell treatment for COPD. And people are working on it. So if you go to the University of wherever, then by all means, take part in some stem cell therapy trials. But the no-name clinic in Phoenix or Mexico that offers you a $15,000 stem cell treatment is probably not in your best interests. COPD treatment, I better zoom along because I've gone over time already. This is what doctors hear about when they hear about COPD treatment. This is the algorithm. This is the doctor's response. It's complicated, and so doctors simplify. They say, okay, I'm going to give Spiriva, I know that name. And then if you come back and say, well, I'm still a little breathless, they'll say, okay, Advair, Symbicort, I know those names. And in 2 visits, most COPD patients end up on what we call triple therapy because there are 2 medicines inside Advair and Symbicort. Medicine, by the way, that includes inhaled steroid. Or sometimes it starts the other way around, the combination Advair and Symbicort, or Symbicort, and Spiriva gets added. I'm just going to point out that these days we're getting back to our roots in COPD. We recognize that the primary treatment that we need to focus on is the bronchodilator. There are 2 flavors of bronchodilators, so we now talk about dual bronchodilators. What you're looking at is another graph of data, but this says if you give one of those anticholinergics like Spiriva, up goes the FEV1, stays up for weeks and weeks and weeks, 64 weeks in this particular study. But if people inhale just once a day and take 2 bronchodilators, things get even better. And this is where we're going, and Darcy mentioned the once a day or sometimes twice a day dual bronchodilators. And we like them not just because FEV1 goes up, but because, as you can see in the orange and green bars, the flare-up rate is higher with one treatment, but in the blue, the exacerbation rate is a little lower when you've got 2 bronchodilators in place. I say all of that because a lot of folks out there are on a triple therapy with inhaled steroids. It's not clear that inhaled steroids are needed. When do we need them? People who have frequent flare-ups need inhaled steroids some of the time. Other times what they need is something else altogether, and it needs to be investigated. And sometimes if your basic problem has included an element of asthma, you can benefit from inhaled steroids. You might say, well, why all the fuss? Why don't I just take them anyway? And the answer is, well, we've discovered some things. The more inhaled steroid you take, that's on the x-axis, the longer you take them, the higher your risk, that's the rising line there, of having a fracture, thin bones. Or there's the rate of pneumonia with a bronchodilator in that a COPD trial, that's the purple bar, 3%. The rate of pneumonia doubles in any of the treatment arms where inhaled steroids are given. And we've discovered that in study after study, inhaled steroids increase the risk of pneumonia in COPD. So what we'd suggest is focusing on the bronchodilators and taking the inhaled steroids only if you have one of those two conditions in play, lots of exacerbations or an asthma element to your problem. There are lots of consequences to exacerbations in alpha-1. All those white cells rush off to defend your lung. That's when the damage is going to be at its peak, and that's when we want to put an end to the exacerbation. I had to introduce you to a classic Canadian study. Professor Jean Bourbeau in Montreal said, you know, if we take, and this wasn't alpha, but if we take COPD patients, after they've been in hospital, treat them as best as we can do for some of them, and this was a randomized trial, a little bit extra. We can give them antibiotic and prednisone pills to have at home. And if they feel that chest cold coming again, that cough and phlegm and the breathlessness, they can call a nurse and see if it's time to start that antibiotic and prednisone. And what you're seeing between the blue and the red are decreased hospitalizations from COPD when patients could start the treatment early, decreased all-cause hospitalization, decreased emergency room visits, decreased office visits. It worked. It's called an action plan. And I raise it in this room because I know one of the common failings I see when alpha-1 patients come to visit is they don't have an action plan. And by the way, let me clarify. I don't mean by an action plan that you've got the phone number for your family doctor's office written down beside the phone. I mean, you've got an antibiotic and or prednisone, but typically prednisone as well, in your travel kit. So you've got it when you go to visit Aunt Nellie on the weekend, and you've got it whenever. So you don't have to phone the family doctor, wait till the end of the long holiday weekend and 2 days beyond that, and get your treatment started 5 days later. Not trying to keep you away from doctors, but trying to make sure that the interaction with your family doctor is, I started this 2 or 3 days ago, I'm feeling a bit better, do I need an x-ray, how am I doing, etc. Not always playing catch up. And this is officially recognized. You can get your family doctor to navigate to the Canadian Thoracic Society website, and they'll find an action plan that they can fill in with you. I wanted to quickly list some brand names, and they're in alphabetical order. These are the newer agents, and so I'll just point out the line that I was emphasizing, the dual bronchodilators, that's here, LABA/LAMAs, Anoro, Inspialto, Ultibro, and then at the bottom, the twice daily Duoclear. Those are the newer agents that focus on that dual bronchodilator. So what's a patient to do? And here we get to a couple of very specific recommendations that I promise you I'll sit down and shut up. Augmentation therapy works. This is a conversation I would have certainly in Ontario, where it's not covered, doctors are a bit slow to get to it. I think the situation is better in this province, but for what it's worth, your doctor should have talked to you about this, and I have been astonished at patients who arrive in my office who've never heard of augmentation therapy and who are clearly candidates for it. If you haven't had this conversation, you should have, and maybe you need to find a new doctor if that conversation hasn't taken place. Treatment needs to be up to date. Your family doctor and your respiratory specialist should be prepared to talk to you about the inhaled therapies that you're taking. Only a minority of patients with COPD need inhaled steroids. I'd say about 1 in 5 at the maximum. The the intent of the inhaled steroids would be frequent exacerbators or people with asthma-like disease. I don't know if Darcy had the same problem, but they're nothing but spots before my eyes. The lights have finally done their job. I think there's a laptop in front of me. And the newer medications focus on that dual bronchodilator approach. A couple of other bits and pieces. Make yourself an expert. I should point out, and I'm not trying to whack away at doctors, but medicine has become a lot more complicated since I qualified as a doctor. And when you've got any disease, it's helpful to know what should be going on so you can prompt your doctor. If you're diplomatic about it, I don't think they'll mind. If you've got a rare disease, that's especially true. So don't rely on your doctor knowing everything that needs to be known and doing everything that needs to be done. Inform your doctor. There are brochures outside that are available from the Alpha1 Foundation in the US. There are brochures that are available and information that are available for doctors from Alpha1 Canada. Share it with your doctor. Give him a copy. Give her a copy. And make sure your doctor has a chance to read about your disease and knows what needs to be done. Keep a binder. I don't know what you want to keep track of. One of the things that I routinely print out for my patients would be a copy of their genotype, which, at least where I practice, is not recorded as part of the electronic medical record. It's a piece of paper that's hard to get, hard to find, and it's good to record that. You should be checking on your augmentation therapy coverage. Again, this might be an Ontario-specific message, but some of our patients don't have private insurance coverage when we meet them, but a year later, perhaps without even changing jobs, their spouses changed jobs, their spouse's employer has changed insurance coverage, and they are covered. So if you're not covered today, keep rechecking. You might be covered tomorrow or next year. Make sure you have an action plan. We just talked about that. And I haven't talked about family screening. Family screening is often neglected. Your kids are at low risk. Your brothers and sisters are at very high risk, 25% of having the full deficiency that you might have. And it can't be checked for with serum levels. It requires genetic testing, and that means probably involving a specialist who knows where to get the genetic testing done. Join the registry. That was my last big important message. And finally, be a squeaky wheel, which is, I think, why you're here today, to learn enough to be very, very squeaky indeed. Thank you. As Darcy said, we're around here for a little while, and you can certainly ask questions after, but if people have questions now, while the confusion is fresh in your mind, I'm happy to answer questions. I hear a voice. I see spots. I hear a voice.
I have a question. Just regarding bronchodilators and taking them multitudes at a time. And what I mean is, I like to play golf or go for a hike. Before I can do that, I find if I take 1 or 2 breaths of Ventolin or salbutamol, wait a minute, and then I take Alvesco because I have a little bit of asthma. Then I take a bronchodilator of Oxys. I wait about 5 minutes, and then I take Ultibro. And I find I can play 18 holes, I can go for a good hike, decent hike. But if I don't do that, and in that order, I'm more out of breath. And I'm wondering, my question to you is, should I take that much at once? Is it harmful, mixing Alvesco with Oxys, with salbutamol, and with Ultibro?
I'm tempted to say, how long have you been doing it? And when you answer 5 years, I'd say, there, it works.
Yeah, I've been doing that combination for about 2 or 3 years.
I don't know why that particular sequence works for you. There used to be instructions for patients to take their quick-acting bronchodilators like Ventolin, salbutamol, before they took their other longer-acting stuff like inhaled steroids, the notion being open up the airways, medicine goes down.
Right.
For most people, that was such a nuisance that they would take the first thing and then forget all the rest.
Right.
And so it tended to be counterproductive, but it's working for you.
That's right.
And my answer is, I wouldn't be concerned. Ultibro is one of the standard maintenance dual bronchodilators. Alvesco is a very gentle inhaled steroid if it's working for you for your asthma component.
Yeah.
As for the other two, they're very similar. I'm not sure why you have used both, but I'm not going to argue about it.
Yeah,
and I just say, in terms of quantifying Ventolin, if you were to come to an emergency room with a bad either episode of asthma or COPD, in my center, you'd probably get about 6 or 8 puffs of Ventolin all at once, and that would be repeated 20 minutes later, probably with some Atrovent mixed in.
Like
So I'm not at all concerned about
like
your use.
Right? When you...
No.
No?
No. Toronto had SARS, which meant we realized that nebulizing drugs produced this wonderful aerosol that distributed a bit of drug, and potentially viruses. So in my center, it's extremely hard to get a nebulizer treatment. You get puffs through a spacer.
Thank you.
Yeah, my question is, I was on Symbicort for quite a while, and I used to get a lot of yeast infections because of the Symbicort. So my doctor put me on Inspiralto, but I found that Inspiralto wasn't nearly as effective as the Symbicort, and she wants to get me back on the Inspiralto. Do you think there's a benefit of either one being better than the other?
They're very different medicines.
Yeah.
Symbicort is an inhaled steroid and what we would call a first-generation LABA, and Inspialto would be two second-generation bronchodilators. What I would wonder, and I'm just thinking out loud, and you have to go back to your doctor and talk about this, is should you, instead of throwing away the Inspialto as a failed trial, say, well, maybe if that's a dual bronchodilator, I should build on it and add an inhaled steroid and add a low dose of inhaled steroid. That's one of the other things that we've learned about COPD. If there is a problem with inhaled steroids, we should probably keep the dosage low. So it's not commonly done by non-specialists, but if the dual bronchodilator isn't enough, you could add a separate inhaled steroid and take that as well. It also depends on what it is you're talking about in terms of your therapy not being enough. Is it the lung function measurement has dropped, or is it symptoms that have increased? And so those are the things to go back with your family to your doctor and talk about.
Yeah, she is a lung specialist. The other thing I have is they were saying about the prednisone and the antibiotics. So if you're, like, I try to stay away from antibiotics as much as I can, you know, to just limit some of the side effects of antibiotics, but they're saying that I should get on antibiotics right away as soon as I have a lung infection.
Take a vote. There's two really smart lung doctors here in the room, Sandy, Darcy, and ask them what they would do. But I think they would say, Alpha1 especially, but certainly even in COPD, you don't wait around like a 17-year-old with healthy lungs to say, maybe this cough is going to go away. I'll wait 3 weeks. You are on it, and you're on it as fast as possible to limit the damage. And again, I think that's especially the case with Alpha1.
You mentioned rounding up the bottles that you should always round up.
Yep.
And I think you were talking about like the studies that are ongoing right now, and they're talking about doubling the doses and possibly that kind of stuff. So if your lung capacity or function is declining, should you be talking to your doctor about upping your dosage? Or is that jumping the gun?
The evidence isn't in about higher doses.
Okay.
So when I say round up to the nearest full vial, I'm just saying don't throw it away. That's an easy decision to make. You're not costing the system anymore. As for going up to, for example, 90 milligrams per kilogram per week, that's an interesting thought. I've seen some prescriptions from the US like that, and I'm wondering if some docs in the US are doing that. I haven't. What I have done is a few of my patients have insisted on taking 120 milligrams per kilogram every 2 weeks for convenience sake. Don't have to explain that in this room. And when they've not had the desired result, when they've tended to decline a bit more rapidly, I've said, let's go back to once a week, which I think is more reliable. So that's as far as I've gone. I haven't been playing with the dosage very much. But I have a feeling I should shut up at this point. Sandy, do you have a thought about that? Oh, there, good, thanks.
It's very controversial about giving higher doses. I personally do give higher doses. We have the luxury in the U.S. that it's often not as hard to get someone on augmentation therapy. And when I have someone on the standard dose whose gas exchange is going down, in other words, the diffusing capacity or the KCO, depending on how it's measured in your pulmonary function lab, if KCO is going down at an accelerated rate, in spite of being on usual doses, I will sometimes try going to a higher dose. If that stabilizes their lung function, then I pat myself on the back and say, done a great job. And if that doesn't stabilize the lung function, I say, well, augmentation therapy might not be the whole story in this patient, and I go back to the usual dose.
And just a thought, I will add as a Canadian perspective, I have never had a pushback when I've adjusted the dosage in Canada. So it seems that once you have approval from a private payer, and I'm talking about Ontario, the dosage is left up to the discretion of the doctor. I'm not sure what it's like in BC, so I don't know if your doctor has some latitude in terms of adjusting dosage. Maybe you could go in with rocks in your pockets and pretend to be a whole lot heavier than you are. I don't.
Do that. Okay, so the main reason why MZs, SEDs, are not recommended to have the augmentation therapy is because we're usually above the protective threshold, right? If more is better, could that recommendation change?
Sorry,
Or is that
oh,
not-
MZs, carriers.
Yes, yes.
Yeah, carriers, unless they are smokers, don't seem to have a huge risk of lung disease, and I don't think there will be any strong move towards giving treatment to carriers. We are looking at other variations. So, for example, the SZ patients who used to be thought to run into few lung problems, we're now recognizing may benefit from augmentation therapy, and there have been some prescriptions in Canada. The newest information about carriers would seem to be that their carrier status has been confirmed as a bit of a cofactor for liver problems. In other words, if something else bad happens to your liver, like a fatty liver, happens a lot in North America, or a hepatitis, the outcome may be a little worse if you're an alpha-1 carrier as opposed to not being an alpha-1 carrier.
Thank you.
All right, thank you.